Hello, welcome to This Week in Medicine, February 28th, 2022. We are saying goodbye to Heart Health Month. So goodbye. Foxhall Foundation's education mission. Dr. Yamamoto frequently gives lectures, and hopefully we'll be doing more of that as we exit from Omicron. We have a Foxhall Foundation with a wellness center. Our nutritionist is doing a great job. And we have active master's classes taught by Mr. Ricky and a Parkinson's class, and we're hoping to expand our class offerings as we exit this pandemic. So what was in the inbox this week? Well, one in particular was the surgeon won't fix my hernia. The problem was a confusion in terminology. The surgeon will fix your hernia, but it needs to be the right kind of hernia. So we're going to discuss some medical terms. And the reason that I thought this would be prudent and applicable is that I saw an entertaining stand-up comedy movie by Ali Wong, which is NFSW, not safe for work. NSFW, not safe for work. So be careful if you watch one of her videos. But she did a great skit on a colonoscopy and what her CAT scan showed, and she thought it was interesting that her CAT scan report said remarkable. We use terms all the time in medicine that are, to lay people, kind of peculiar. When we say you have remarkable findings on your CAT scan report or your MRI, we don't mean that it's remarkable, congratulations. We mean remarkable, there's something wrong. So I'm going to use this session of This Week in Medicine to discuss some medical terminology, and we'll try and work on that a little bit more because it's quite clear that we doctors, nurses, medical staff use a lot of terminology that to the layperson can make them quite confused. And certainly the whole hernia issue this week was a case in point. Other things in the inbox, the antigen test is still not negative. Still seeing some of this where these patients, I'm sorry for you, still are not negative at day 8, 9, 10, 11, 12. Some people it took 13 days to become negative with their testing. Also, there are some patients still who definitely have symptoms of Omicron, but their PCR test is even negative. The mask mandates are lifting, but not necessarily in all the schools. Maybe in another week or two, we'll have masks lifted in schools and healthcare settings. But remember, in your healthcare settings, it really could be that you're with immunocompromised people, in particular, of course, if you're in the oncology part of a hospital or an infusion center. So there may be patients there who are on chemotherapy or have cancer, and those patients' immune systems don't work as well. There's still an ongoing trial of an Omicron booster. We should have that data out soon. No fourth shot is needed for most of us, so we don't have to get a fourth shot. And the question of to mask or not to mask, that's a difficult one. So I think as we exit this long 2-year pandemic, the question of when you want to mask, do you still want to mask on an airplane? Do you still want to mask in a subway? Are there other viruses that we need to be concerned about? Other respiratory pathogens that might come out? So I think the issue is to respect people when they do want to mask. It's not our business to know when somebody wants to protect themselves from respiratory pathogens. Some people are doing this because they do have weak immune systems. And it's not their business to tell us they have a weak immune system. It's not their business to tell us they're on chemotherapy. So I think a general climate of respect for people who still want to wear a mask is a good approach. They're not forcing it on you, they're protecting themselves. And yes, wearing a mask can protect yourself from a respiratory pathogen. So let's go ahead and see what we have for this week. Again, just to remind everybody, this was a good article about the fourth shot. I'm still getting quite a few emails with people requesting should they have a fourth booster shot. So again, this article was very well done. It was in the New York Times, and it discussed why we probably have good enough immunity with 2 and even 3 shots. We're saying goodbye to February Heart Health Month. So remember, find out about your blood pressure and your heart rate, not just blood pressure, and your over cardiovascular health. And remember that this is a lot involved in aging. So it's not just heart disease, it's heart aging. So even though the focus of this past month was on heart disease and stroke prevention, some of this really is just cardiovascular aging. So if you even have an awareness of where you are in your cardiovascular age spectrum, that's helpful as well. You don't have to think of it as a disease, just think of it of where you are in your cardiovascular wellness. Okay, so we're going to talk about gastrointestinal terminology. We might not get through all of this today because I don't want to bore you too much. There are hiatal hernias, ingrinal hernias, periumbilical hernias, ventral or epigastric hernias, and even the famous and elusive spaghelion hernia. There's another term that we use, a tortuous colon. This doesn't mean that your colon is torturing you, although it may. Tortuous means that it's twisty. Typically, a colon is a straight shot. It's ascending, transverse, and descending. So it has 3 major segments. But for some people, their colon in 3 segments does a lot of twisting and turning, like a small intestine. For those people, they do have a tortuosum colon. It might bother them with constipation. So you will hear this terminology thrown around a bit, especially if you're somebody who just had a colonoscopy. Don't be surprised. There are a lot of people with different types of colons that we see. When we tell you that you might have a stomach ulcer, or we're worried about you having heartburn or reflux, a procedure we might recommend is the EGD, which is much easier to say than esophagogastroduodenoscopy. Esophago is your esophagus. Gastro is your stomach. Duodeno is your small intestine. So this is a continuous line from your mouth to your esophagus, down to your stomach, and then to the first part of your small intestine, which is called the duodenum. So that's as far as the scope typically goes. It's also just called an upper endoscopy. So all of that is the same. I think we all know what the colonoscopy is. The colonoscopy typically looks at your entire colon and a little bit of the end of the small intestine called the terminal ileum. When we were talking here about EGD, one of the reasons we would do an EGD is if you had GERD. What is GERD? Gastroesophageal reflux. It's also similar to esophagitis. It's the esophagus and the gastro, the stomach, that are exposed to acid. And if there's too much acid and that acid goes up to the level of your throat, the back of your mouth, that is what we call GERD or esophagitis. Finally, another term is a small bowel obstruction. It may not be that there's something actually obstructing your intestine. If it's an ileus, ileus comes from the word ileum, which is a word we use for the small intestine. If you have an ileus, the small intestine may not be squeezing, and so it stops in its tracks. Intestines should never stop in their tracks. They should always be squeezing a bit. So we'll talk about that eventually, probably not today. So let's talk about the hernias. So hiatal hernia, you can think of it as going on a hiatus from its usual position under the diaphragm. I'll show you some pictures. So hiatus also means an opening. So we'll look at that in a minute with a picture. But a hiatal hernia is typically not a surgically corrected hernia. So we have the surgically corrected hernias, like the ingrinal hernia, and we have hiatal hernias, not typically surgically corrected. It's too bad because this creates a lot of confusion, and it created some confusion this week because a surgeon, especially a general surgeon, will do a lot of hernia corrections, but usually you need a specialty surgeon to do a hiatal hernia correction. So it's not considered in the category really of surgical hernias like an ingrinal hernia in your groin or an incisional hernia. Incisional means it's a hernia that happened because the surgical wound did not entirely stay closed. You can get a hiatal hernia from pregnancy. The baby in the uterus can push up on the stomach and make it sneak through the opening in the diaphragm. Weight gain can do this too. Thoracic kyphosis we will look at a picture of. Sometimes maybe an acute episode of vomiting if it's strong enough, or an attack of esophagitis if it's strong enough, or maybe you just have stretchy tissues and that causes your stomach to go up through your diaphragm where it's not supposed to be. So this is the normal situation. Here's your diaphragm. Hiatus again, opening, or if we want to try and remember what a hiatal hernia is, it's taken a hiatus from its position under the diaphragm. So this is when the stomach sneaks up through this natural hole in the diaphragm. That hole belongs there so the esophagus can get through, but it sneaks up through that hole, and all of a sudden you have part of your stomach above your diaphragm. So if part of your stomach is above your diaphragm, that is called a hiatal hernia. I do have some patients who have a lot of their stomach above their diaphragm. So imagine if half of your stomach or a third of your stomach snuck through this hole in the diaphragm, it was up in your chest. So we can actually see that on a chest x-ray. You can see the bubble of the stomach on a chest x-ray that sits right here where the lungs and the heart should be. So that is the hiatal hernia. Again, this is normal. You have a sphincter, which is a muscle. This closes and opens. It opens when you belch. It closes after you've eaten dinner and you want to get that food out of your stomach. But if part of your stomach has slid through this hole because your stomach got pushed up by being pregnant, your stomach was pushed up because you had a violent cough, now your sphincter muscle is above your diaphragm, and it doesn't look like it works as well, does it? And that's what they're trying to show in this picture, that the sphincter is not closing as well. So because part of your stomach is now above your diaphragm, your sphincter is above your diaphragm, you can have stomach acid generated here that shoots up to your throat and your chest and gives you heartburn. Thoracic kyphosis can cause hiatal hernia. So how can this happen? Well, as we get older, and this is actually taken from a Pilates book, you can start experiencing some curvature that eventually leads you to this condition called thoracic, because that's your thorax, and then kyphosis is this curvature. As that happens, your stomach can move up into your chest because it's no longer this straight anymore. And look at the height difference as she gets older. Where is that height going? That height is losing itself in this curvature so that your stomach is going to move up into your chest. I see this a lot in older women, in particular in women who make it into their 90s. We can try very hard to keep our posture straight, but some of this is just disc degeneration and age. Some of it's osteoporosis, but some of it honestly is just the aging process when we lose our discs. But it can contribute to the stomach moving up into the chest. And in those cases, these patients can experience significant chest discomfort, significant reflux and heartburn. And probably the easiest thing to do for these patients, because we can't prevent it once it's already there, is just to treat them as if they have chronic reflux, because we're not going to easily get that stomach back down into the abdominal cavity. So treatment of hiatal hernia: sit up straight. Don't lay down for 3 hours after eating. If you have a hiatal hernia, if you've been told your CAT scan shows it, your upper endoscopy shows it, even your chest x-ray might show it, don't be surprised. A lot of people have hiatal hernia. Since pregnancy creates it, a lot of women who've been pregnant have hiatal hernia. Since being overweight can create it, a lot of people who have a big abdomen can have it. So try not to exacerbate it or trigger it by laying down, because as soon as you lay down, remember that picture of part of your stomach being above your diaphragm? That encourages the food in your stomach to go up with the stomach acid past the hole in the diaphragm. And since that sphincter is not really competent anymore, then you get some stomach acid up there in your esophagus. And the hiatal hernia is encouraging that as well. Eat and chew slowly. If you need to, you can take a medication. I do prefer medications for my patients in their 90s as opposed to surgery for hiatal hernias, which again is not the primary treatment. Proton pump inhibitors, Prilosec, Nexium. The generic name, notice, they all end in prazole, omeprazole, lansoprazole, pantoprazole, esomeprazole. These are all generic versions of the name brand Prilosec, Nexium, Prevacid. These inhibit the proton or acid pumps in your stomach, and by changing the pH in your stomach, making your gastric stomach contents less acidic, you're less likely to exacerbate your hiatal hernia. You can also take H2 histamine blockers, not histamine blockers like we use for allergy. Those are H1 inhibitors like Claritin and Allegra. These are H2 blockers, and the only one we have out right now easily available is famotidine or Pepcid. There are other ones on the market, but they're not as easy to get as famotidine. We used to have Zantac or ranitidine, and as we've talked about before, that was taken off the market probably for incorrect reasons. Some people episodically will take a Tums, some Gaviscon, Rolaids, even baking soda and water to help alleviate the symptoms of their hiatal hernia. And then again, very rarely we do surgery. In fact, you really need a specialty surgeon for this. This is not something a general surgeon will do. You want someone who does a lot of these surgeries and has a high success rate, because this is not typically a super guaranteed successful surgery. So if I'm doing this for someone who has a large hiatal hernia, most of their stomach may be in their chest, you really want to go to a national expert on this. And again, this is thankfully a very small percentage of people with hiatal hernia. All right, the surgical hernias. You can have an incisional hernia, which is when your wound that was closed surgically maybe stretches too much and opens, and contents come through that hernia. Ingrinal hernia, which is the groin. There are ventral or epigastric hernias, which can get confused for hiatal hernias because they're in a similar location, but they're very different in how they're treated. The elusive spaghelion hernia, very hard to find, very hard for a surgeon to find. Umbilical hernia, which is an innie or an outie belly button. So if you have an outie belly button, you probably have an umbilical hernia. What is a hernia? That's when your intestines are pushing through a hole in the covering tissues over the intestines, and that includes abdominal wall muscle, abdominal wall fat, and something called fascia, which is a white connective tissue that keeps everything in your abdomen. So I apologize for the pictures, but this is really the only way to easily show you what a hernia is without being too graphic, but graphic enough that you understand. So a ventral hernia is in the front of the abdomen, so anywhere from here down. We also call them epigastric hernias. They can be right above the belly button, and you can see these are the intestines. They have come through the thin muscle layer of the abdominal wall into the fat that's under the skin. This is all the skin. And then there's some peritoneum or connective tissue, the fascial tissue, that's still going around the hernia, but we really don't want that intestine there. We want to tuck it back in and reconnect these layers, and that's what a surgeon does. The ingrinal or groin hernia, men and women can get it. So that comes through in the groin area. You have skin, again you have some fat, and this intestine came through the muscle. This is the muscle in the wall, and it's sticking out. Why do we care about that? Well, I'm sure many of you have heard of an incarcerated hernia or a strangulated hernia. If this tissue pinches this area off, if it pinches hard enough, it loses its blood supply, and then that intestine is in jeopardy of death. So that typically is a lot of pain, it's redness, it's not something that's subtle, it's usually pretty obvious when these hernias hurt. You can have them sitting here without strangulation, but if they are going to strangulate or there's a high risk because this area is very narrow, that's when we refer you for surgical evaluation. Interestingly enough, when the area is very big and the opening is very big, the hernia will be bigger, but the risk of strangulation may be less because the opening is so big. The ventral or epigastric hernia I was talking about on this picture, it's above the belly button. That's where they tend to be. This one's kind of small, and honestly, they don't usually sit out like this. I do have a couple of patients who've coughed these out, had such bad coughing spells that the intestines basically came through the layers of the abdominal wall. This can be easily tucked back in with surgery. This is an example of an incisional hernia. Again, they show this graphically with the stitches in the abdomen, so you can see where surgery was done, but that it didn't hold the abdominal contents in sufficiently. So diastasis recti is not a hernia, and I think I probably see patients with this a couple of times a year. It happens if you have a big abdomen, so if you have the famous beer belly, or if you've been pregnant. When your abdomen gets big, it pushes the rectus muscles to the side, but the fascial tissue, the connective tissue, is still intact. So there's no intestine coming through here. That is not what this is. You can see this if you're lying flat and you raise your body up, use your abdominal muscles to raise yourself up, you can see this bulge come through. And it comes through because your rectus muscles have separated. That's not a hernia. The reason it's not a hernia is that there's no intestine coming through the center part. The intestines are still well tucked below. You'll see a bulge for sure, but your intestines are encased and protected. So this is just diastasis, and it can happen from pregnancy, from your belly being too big, again, from weak tissue layer, but you don't have to do surgery for this. And if you have to come into your doctor's office to see what the difference is between the ventral or epigastric hernia and the diastasis hernia, which is not really a hernia, that's okay. That's what we doctors are here for. We're happy to tell you what this is. Here's the umbilical hernia. Again, we talked about this being the outie belly button. You can let these alone. If it doesn't bother you, you don't have to fix it. I did have a patient who is a marathon runner, and she did not like this periumbilical hernia. When she ran, it bounced up and down, and it really irritated and aggravated her. So she had a surgeon fix it, and it was a pretty simple fix. We can tuck these in pretty easily. Again, a very simple surgery. You don't have to get this done. A lot of people have outie belly buttons. It's okay. Just make sure your doctor has seen it. Finally, the elusive spaghelion hernia. These can happen just a little bit above the belly button on either side or below. This is a complicated picture of all the abdominal wall muscles, and you can see how this little section right here, this break between the sets of muscles, could lead to a bulge of the intestines that comes out. But this is a very rare hernia. It really takes a good surgeon to diagnose this. It's not common at all. Tony's tip of the week, remember to update your new insurance. If you get new insurance cards, you have to let us know right away, because if we are sending your insurance cards to an imaging facility, radiology facility, or a referring physician because you're going for an appointment, they may not even do it unless they have your updated insurance card. So we always need that so that we can make your referrals. Also, remember to update any new addresses that you have and which is your primary address. We're fortunate enough to live in an area where people have 2 or 3 addresses, but we would like to know what your address is. Always confirm your email address with us because we use those a lot and they do change. So if you have a new email address, let us know and confirm it when you ask, because sometimes we just don't have it listed correctly. Fast pitch, remember we're leaving February, Heart Health Month. Blood pressure is just a number. It requires context for us to understand what it means for you. Remember the difference between a surgical versus a hiatal hernia? You don't want to go to a general surgeon and say, can you please fix my hiatal hernia? No, because a hiatal hernia is really not surgical. It's your stomach escaping through that hole in your diaphragm into your chest. Some people still do need to mask, so make sure that you keep that in mind if you're out and about. And as flu season arrives in the fall, maybe we should all consider masking again, because it certainly did keep down influenza for the past 2 years. We're just finishing flu season again, end of February, and I have not had a single patient with influenza this flu season. So that's it for this week. Thank you for your attention. Remember, pay attention to your health pyramid and get a copy of our book if you haven't read it yet. And if you can, use a Google account to subscribe to our website and to our This Week in Medicine. Thank you for your attention.